Welcome to NHS Advances in Oncology and our segment on Handle with Care, Healthcare Worker Safety. My name is Christine Clark and I'm a pharmacist and the editor of Hospital Pharmacy Europe. Joining me today is Jim Jorgensen, Chief Pharmacy Officer and Vice President of Indiana University Health. Jim, I understand that IU is the largest and most comprehensive facility in the state.
It is. IU Health is comprised of 19 hospitals, ranging in size from 15-bed rural hospitals all the way up to 1,000 beds. It's anchored by Indiana University Medical Center in Indianapolis, which also includes the Indiana University Health Simon Cancer Specialty Hospital, Riley Hospital for Children, and then a number of ambulatory clinics, which include 12 oncology infusion centers, and we're scattered throughout the state.
Tell me about the importance of protecting healthcare workers from exposure to cytotoxics.
Well, I think at the most basic common sense level, if you look at the issue, the same mechanism that these drugs use to kill cancer cells also damage healthy cells. So of course we're concerned about making sure that that exposure isn't present in our healthcare workers. And there's more drugs than just cancer chemotherapy that are considered hazardous. The World Health Organization came out with the first definition of what constitutes a hazardous medication, and that's been picked up subsequently by a number of professional groups, including the American Society of Health System Pharmacists. A drug is considered hazardous if it hits one of 6 categories. So if in small doses, the drug exhibits one or more of the following characteristics, so that if it causes reproductive damage, if it can cause developmental or teratogenic damage, if it can cause genetic damage, if it's carcinogenic, or if it causes end organ damage, it's considered hazardous. Or if it's a new drug and it's similar in structure to a drug that's already been proven to be hazardous, it's also considered hazardous. Previous to about 1970, as I mentioned, there wasn't a lot of attention being paid, but then we started to see more and more reports in the literature of side effects similar to what we were seeing in our patients showing up in healthcare workers, predominantly oncology nurses. So we're seeing those same kind of acute side effects of hair loss, mucosal sores, skin irritation, nausea, vomiting, dizziness that we would see in patients. And then as we began to look at this more, we started to see more and more literature reports of long-term effects associated with those 5 categories: reproductive damage, end organ damage, cancer, genetic damage, and teratogenic events occurring in healthcare workers. That promulgated a wide variety of standards to improve safe handling. So organizations in the United States, such as the National Institute of Occupational Safety and Health, Oncology Nursing Society, American Society of Health System Pharmacists, to name a few, and then internationally, groups such as the International Society of Oncology Pharmacy Practitioners have all continued to come out with enhanced standards around safe handling. Now, there's a number of standards, as I mentioned, designed to help protect us, but I think probably some of the most comprehensive are the ISOP, or the International Society of Oncology Pharmacy Practitioner standards, because those were a cooperative effort from around the globe. So the standards committee comprised 14 pharmacists from a variety of different countries, and they were actually charged with compiling all of the standards and guidelines from the various countries into one comprehensive document. And I think they came up with a very eloquent approach to safe handling, where they adopted a hierarchical model from an industrial hygiene, where they looked at doing the most safe thing you could do and then working down to the least safe thing that you can do. And I think too often as healthcare practitioners, we start at the bottom and work up. So if you look at the ISOP hierarchy, the first thing that they suggest is don't use the hazardous agent or substitute an agent that's less hazardous. But of course, with cancer chemotherapy, you can't really do that because they're all hazardous. The next thing that they suggest is contain the hazardous drugs so that it never gets into the external environment. That would be where closed system drug transfer devices come in. And then you step down to what they term engineering controls, which are really primary engineering controls, which would be compounding aseptic isolators or biological safety cabinets, so that if the drug did make it out of a closed system, it would be contained in the primary engineering control and vented to the outside and rendered harmless. And then you have secondary engineering controls, which would be the negative pressure room that the isolator or biological safety cabinet is located in. So if it made it through the first 2 fail-safes, the room would contain it and vent it. Then you go down another level to the policies and procedures that we all employ for safe handling. And then finally at the bottom of the hierarchy is the personal protective equipment. So if it did make it all the way through, hopefully then it would minimize any operator exposure at the end.
So with all these measures, why is drug transfer safety still important?
When I was at the University of Utah, I actually had the unique experience of being able to build and design 2 pharmacies dedicated exclusively to the production and distribution of cancer chemotherapy agents. And they were a well-funded endeavor, so I had the opportunity to over-engineer these pharmacies and build them up to all the current levels of standards. This was prior to the introduction of closed system drug transfer technology, however, so when we built them, I decided I would test them. So we did surface wipe sampling in the pharmacies and in the patient care areas after 3 months of operation, and we looked for cyclophosphamide and ifosfamide. And what we found was that 100% of the samples in the pharmacy and in the patient care area were contaminated. They showed evidence of one or both drugs. And then we actually took that one step further, and we did 24-hour urine collections on all of the nurses, pharmacists, and pharmacy technicians working in those areas to see if there was any evidence of biocontamination in the healthcare workers. And what we found was 100% of the nurses had measurable levels of one or both drugs, 100% of the pharmacists had measurable levels of one or both drugs, and 30% of the technicians did. And we were deploying all of the current standards. So that said to us that despite our best efforts, it wasn't enough. There's been a number of studies that have actually used fluorescein dye as a surrogate marker for chemotherapy. So they've simulated chemotherapy manipulation and administration and then photographed the results under UV light so you can graphically see any evidence of contamination. And you can clearly see evidence in the biological safety cabinet, in transport vehicles, in work surfaces outside the pharmacy, and then in non-traditional surfaces like sinks and telephones. Again, illustrating that once this stuff gets out, it migrates everywhere.
Describe for me BD's closed system transfer innovations.
I think there's a number of products on the market right now in the closed system sphere, and I think that's great because the more products it helps raise awareness around safe handling. BD is unique, though, in that it has the majority of clinical studies to document that it meets the NIOSH and ISOP definition of closed, as well as that when it's added to a complete safe handling system, it helps to minimize or reduce exposure. The accepted definition for a closed system transfer device is a device that mechanically prevents the entry of contaminants into the system or the escape of drug or drug vapor out of the system, essentially a system that's leak-proof and airtight.
And how are you using fasil in your institution?
We've decided that we are going to deploy the BD fasil unit across all of our organizations that handle cancer chemotherapy. So we've got it in all 19 hospitals, and we've got it in all 12 of our infusion sites. So we use it in the pharmacy for preparation of all chemotherapy agents, which includes monoclonal antibodies for us, and we use it in the nursing areas for administration of those agents. And that also includes areas where we're using chemotherapy agents for non-cancer patients, such as dermatology or rheumatology or obstetrics. And we also use it in our investigational drug service where we're working with any investigational products that we would deem to be hazardous as well.
Are there any additional benefits to the BD fasil device?
I think to date, most of the literature worldwide has focused on the second part of that definition, the escape of drug or drug vapor out of the system. But we've started to look at the first part as well, the prevention of contaminants entering the system. And our real impetus for that was drug shortages. We're facing a real crisis right now with well over 200 drugs in shortage situations, and that can be an absolute shortage where you simply can't get any more drug, or a relative shortage where you can't get as much as you need. And 22 of the drugs that we're tracking right now are cancer chemotherapy agents, and many of those are single-use vials. And in the United States, we practice to the United States Pharmacopoeia Chapter 797 standards on safe handling. And they stipulate that if you open a single-use vial outside of ISO 5 air conditions, so outside of a biological safety cabinet or isolator, you have to throw any leftover drug away after an hour. If you open it and maintain it in ISO 5 air, though, you can use it for 6 hours, and then you have to discard the drug. So clearly with drugs that are in short supply, where we don't have enough to treat all of our patients, we're not real excited about throwing away product that's chemically stable because we may have contaminated. But the USP gives you the opportunity to extend the beyond use dating for those drugs, the BUD, if you have documented evidence that you can safely move that beyond use dating out. And so we've focused on using the BD fasil product because it does maintain a closed system to extend that beyond use dating, allowing us to use more of the product without having to throw it away. That helps with drug shortages. The second thing that we found as an offshoot of that is it helps reduce waste significantly. In the United States, because of that requirement of 6 hours or 1 hour, we end up throwing away a significant amount of drug product that's chemically stable. And in studies done at the University of North Carolina and our own studies, that could be up to $1 million per institution. So if you extrapolate that out across the country, that's probably billions of dollars of drug every year that's chemically stable that's being thrown away. So there's a big opportunity for us to actually deploy the BD fasil system to help reduce waste as well as extend our ability to use more of the drug in those shortage situations.
I'm sure that these results will be of great interest to the National Health Service because safety with savings is always attractive. Thank you very much, Jim Jorgensen.
Thank you, Christine.